I will talk about the basics, how the two of us started 10 years ago, and tell you how it looks now. So this is 10 years ago when we started. Everybody looks a bit younger, even me. So we had two ORs, one neuronavigation system, one intraoperative neuromonitoring device, and we did everything asleep only. At the school where I came from, you just heard, we never did awake surgeries because it was a huge epilepsy center and we had a lot of epilepsy cases, and we're used to do the out-of-the-OR electrophysiology and then take the results in the OR and do our surgery that way. If we wouldn't have had NTMS introduced and wouldn't have had language mapping, I probably wouldn't have switched to awake craniotomies because this is for me purely out of scientific reasons and not because I believe in its superiority. So why did we acquire NTMS in the first place? When I saw the device, and I date back to electrophysiology a very long time ago. Actually, my first publication was on MEP monitoring in 1989, and together with Dr. Zentner. So I was highly interested in that method because it was the first one where I thought that it could be something that could localize function in the brain with an adequate accuracy for a neurosurgeon. And it looked as if it was easily integrated into the workflow, so we started on it, and Sandro Krieg was the one who took responsibility for the group. So the surgical aims, this is a slide from the meeting in 2010. The surgical aims were obviously always the same: to maximize the extent of resection, improve such survival, which is, at least in the year 2019, a given for almost everybody. And you want to preserve neurological function, so to increase quality of life for the patients. This is still true, and before we had NTMS, our multimodal approach to these patients were driven by what I knew, and this was, we were taking the anatomical DTI fiber tracking. That was seeds that were automatically given them by the system, and we had intraoperative monitoring where we did direct cortical stimulation and subcortical stimulation. fMRI was something I had, but I never even looked at it because I did never think that it was even remotely adequate for localizing the function that we needed. Produced hip pictures, but that's all. So how did we connect that? This is a picture from then where you can see that we had a navigation system and we had the intraoperative navigation added, then the electrophysiological monitoring, and then we had the first NTMS case, and we were obviously very much excited about the accuracy, where you could see the hand function and everything else was in the surrounding of this tumor, which was in the center, in the precentral gyrus. This was the second case then that we did, again in the precentral gyrus, or obviously anatomically seen in the precentral gyrus. And if you looked at it, this was the first one where we could see that there was an obvious mismatch of the fMRI versus the NTMS. And this was then in the sequence also reproduced several times, several cases, by one of the earliest publications that Sandro Krieg's group authors. So this had immediate consequences, how to access the tumor. If we would have taken the fMRI into account, we would have taken a different corridor and gone through the fiber tracts and probably would have had a paresis. So it's a very basic and easy thing, but it did make a definitive difference as opposed to using fMRI, or as opposed to using your gut feeling of where to come into that. So there was then the first thing that was developed, that the DTI fiber tracking was improved drastically with the use of NTMS, as opposed to the automated process of having seeds generated by the machine itself. You would use the dots where you could see the hand function to start with that. That is something that made the fibers a lot more robust and clearer, and less aberrant fibers, so you could basically rely on what you see, no matter how much edema was in the brain or etc. This is one of those pictures that we produced. That was also in a second publication, I think, or I don't know if it was the second, but one of the publications, the early publications, proven that there is a marked difference between the automated generated fibers and the ones that originated from the seeds of the NTMS. With that, you could then track your subcortical stimulation electrode, or even we had it then built in the CUSA, so you track your CUSA or your electrode, and then there's not a lot of fiddling around and searching with just pure electrophysiology. You could just go where you could see the fiber tracks and then start your approaching towards the fiber tracks with reducing the milliamps that you use to stimulate. So that makes things easier. It's always small steps, but it's if you add every small step, you come probably to a big step, at least for me as a surgeon. So this was then approached with NTMS, where motor language cortex. We completely abandoned fMRI. In our setting, we only have NTMS, and for the long tracks, we had then the NTMS-based DTI fiber tracks. We would have had the NTMS-guided subcortical stimulation, and we had the direct cortical stimulation, obviously, as we had before, abandoned in favor of just putting the electrode where we thought we had the motor strip located with the NTMS. So the first studies then were out of if this is something the surgeon could use, which is basically essential for the acceptance of a method. And the surgeons answered in a very positive manner in every aspect. They were safe, they felt safer, the things were easier for them, they had more confidence, they were more thorough in taking the tumor out, and even more aggressive. And in a considerable percentage of cases, that's about 10 to 20%, which is considerable, you would change your surgical strategy according to your preoperative mapping. Patient's perspective then obviously was to take into account, because there was considerations of do we induce seizures, blah blah blah, and so most patients said no, that's not a problem. It's neither unpleasant. We didn't induce any seizures, and only some patients in a while now say that it's unpleasant. Nobody ever said it's painful, because electromagnetic stimulation nowadays, it's not painful. When I started doing this with Dr. Zentner, we used electric stimulation, which was extremely painful to the patient, as I record, but that's 30 years ago, so nowadays you couldn't do this anymore. So first studies on NTMS accuracy, not only us, groups here in San Francisco and the usual round of suspects showed all the same, that it's highly accurate, and the gold standard as direct cortical stimulation was basically within a millimeter around what you saw on the picture, which is very good. And a tiny step, but a very good step in the right direction if you look at it from a distant perspective. So then in 2011 already the project language mapping started, which was expected to be a lot more difficult than motor mapping, because language is obviously something which is extremely complex. It is, you probably hear about that later on, so I don't elaborate on that, how it all started. But basically you inhibit language by the impulse and generate then the map accordingly. So these were the first, I think maybe even the first patient that was mapped in 2011. That's how it looks. A little bit on the awkward side yet, because it wasn't quite clear what we see, but what became clear initially, that there's also in the complexity of language a difference between the anterior and posterior language areas. Why the anterior, that is the expressive language part, is easier to define. The posterior is obviously a lot more difficult to define. So this is again a key case, like the first one that I showed you for motor mapping. Someone who had this type of tumor, which is obviously on the left-hand side in the Broca area, but the fMRI showed that language is exclusively on the right-hand side and no language on the left-hand side. But then the mapping showed a different picture. It has been shown before, by the way, by a very old method, the VADA testing, that there is 20% false positive or wrong localization of language if you use fMRI. That's, I think that has been published in 1995 or something like that. So we already in Bonn, we never trusted any fMRI localization of language. So this meant that it clearly changed the strategy on how you would tackle that tumor. If you had the idea that the patient only spoke with his right hemisphere, you would have taken the tumor out with any consequences or looking at it. So this is one of the first awake craniotomies that we did then in Munich. Despite the fact that it's now completely integrated in the workflow, I will end with that. It is still painful for me, to be honest, because I have always a problematic issue with seeing the patient's reaction. I would say about 60% of patients react in a manner that makes me uneasy of what I do. If I compare that, well, since I'm old enough, I can do that, to what I've done in these tumors when they were mapped outside. I don't think that in the end, if you compare 100 patients that I have done earlier with 100 patients that I do now under these circumstances, there's a big difference in my outcome. So this is purely for actually scientific or clinical scientific reasons that I do this. Whoever of my attendings likes to do it can do it. So I don't think this is the post-op picture of this patient. So these were one of the first publications that year, and in accordance with what we did with motor mapping, this was then done also for fiber tracking for language pathways. Was the logical next step. The dots are then magnified and then taken as a seed for the language pathways. There were a couple of other publications on that topic, also the interhemispheric connection, where a theory was built up that I don't understand, but I do obviously duly believe in it, since the group said so. But it's something which is useful. Because it gives you clearly an idea, and I will show you cases later on where to go or not to go in these type of things. Finally, higher functions were then started, starting with calculation, for example. By Dr. Maurer, this publication in Brain Structure and Function about non-invasive mapping of calculation function in the same way that language was mapped. This is a case where arithmetic processing was correlated with what was seen in outside monitoring. It's published this year in World Neurosurgery. It has, as usual, a very high sensitivity. and a very actually low specificity. That is the same for language, by the way. So if you don't see anything in that spot, you can be basically sure there's nothing. But if you see something, you have a 50-50 chance that there is nothing or there is something, which is better than nothing, but obviously you would like to have a better specificity. I don't know how to reach that, but probably it will take some more time. So how do I use NTMS today to conclude what we do, not only me? This is a typical case for a motor mapping where I think it's very useful to have it. That's a recurrent glioblastoma, recurring after 6 years of the first resection and adjuvant therapy in basically what would be anatomically the hand knob. If you look at the 3D reconstruction of that, you can see that there is a corridor of access directly above the tumor. And if you translate that in the OR, you see the whole, basically in the precentral gyrus where the tumor was, and under, without any direct cortical stimulation of the motor cortex, we just proceeded with continuous MEP monitoring to resect that tumor, and this is the post-op image, and the patient didn't have a deficit. That's a typical case. Then a case where we would use language tractography in this very diffuse recurrent anaplastic astrocytoma. Let me stop that and go on. That's actually a girl, not a boy, with a pilocytic astrocytoma that was referred to me actually from my hometown because I knew the parents. These are 2 pilocytic astrocytomas, and the girl developed an increased intracranial pressure, and this is why she was taken to surgery there, and they took out part of it, of the huge lesion there, and the pathologist said it's a glioblastoma, which I did never believe in the first instance. So we said, well, this must be a pilocytic astrocytoma, which was then actually with our neuropathologist confirmed, and we said we need to take out at least a large lesion, which we did. And we could see with subcortical mapping until the very end that the fiber tracts were intact and everything, which are, this is very, very, very close, and it was clear that the girl would have a deficit afterwards. I saw her about 3 months later. She was completely intact, minus the tumor. That's a 3-month control. This is, and the thing what it is essential for me in this instance to see exactly where the fiber tracts are and to use subcortical monitoring is because otherwise it disrupts your workflow. If you search for the fibers with a subcortical electrode in a manner that you increase or decrease the milliamps with which you stimulate, you never get into a flow to reduce the tumor or to resect the tumor, and you will probably leave tumor inside because of fatigue or because of frustration, etc. That's another example for someone with a tumor where we use subcortical stimulation in a routine manner. See the resection cavity, and we would then would have the electrode connected to the navigation system and go right there, and then we would go to the 5 milliamp resection margin. In the girl, I was below that. This is the reason why she had a post-op deficit then, and it was obvious taking a risk in that instance because you never know if it recovers or not. A 5 milliamp, according to me, is a safe margin where you don't have to fear anything. That's post-op. Again, something, a ganglioglioma, which turned into a malignant ganglioglioma, a rare case, but it happens, had been resected outside several years before in his childhood. PET positive thing, and this makes it actually very easy to plan your corridor where you go there, and how to resect it, and what type of intraoperative monitoring you use. So this was then the first case where we did an elastic fusion of intraoperative MRI data, and this is the result. And you see, this is something you can use actually in the OR. It's not just something you have on paper, and it doesn't work. So now, 10 years later, it's completely integrated in the workflow. Actually, basically every patient gets a mapping, and it's done in a way that it's within our routine. So despite the fact that it's used, obviously, to generate scientific data, it is completely also a clinical routine and accepted as that. These are the OR data. That's the way they look like. They can be stored in the system that we have. Oops, these were the data in the system, in the clinical system. Then I never knew with this animation. Here it goes. So this is an excerpt from our system that we have. Then if you do the mapping and do the documentation of it, I can go through that a little bit quicker, just to show you that it works. That you get the reports and you can send them out to insurances. You can see them in your system. Everybody can look at it, etc., etc. When does this stop? Dr. Grieg likes this slide. Well, so this is the current setup that we have. We have 4 ORs. We have 1 intraoperative CT, 1 intraoperative MRI. We got 4 neuronavigation devices, corresponding microscopes. We have NTMS fully integrated in the workflow, as you've seen. We have 3 intraoperative monitoring devices, and we do roughly 20 to 40 awake procedures a year. This is not a lot, but we have a very high, or I have a very high threshold of doing awake craniotomies, but that's about what we have. So this is in pre-NMS times, where we just had an idea where language and everything was, and maybe had our own projection then on how to attack tumors, and this is actually what it looks today. And that's it. Thank you very much.